being here to talk about where we're going with these diseases.
Thanks, David, and thanks everyone for sticking around to hear this last talk before lunch, which is always a difficult talk to give. So I've been charged with giving the talk about new drugs for MPNs, and that is what I shall do. These are my disclosures. These are all really based on clinical trial work that I do that gets paid to my institution. What I'm going to hope to cover, hopefully within the time frame, are different approaches. So JAK2 inhibitors and JAK-based combinations, things that are maybe not as new today as they were several years ago, but I'll still talk about them, like pentraxin-2 analogs and telomerase inhibitors. And then things that are kind of cool that are emerging, like SMAC mimetics, activin ligand traps, bromodomain inhibitors, and then something I'm passionate about now, MDM2 antagonism. So what I won't do in this talk is really talk a lot about JAK inhibitors, which is a talk in itself, but I'll just sort of review for the group that this is sort of the pathway to approval as I see it. So in red, you see the ones that have unfortunately failed, typically due to toxicity issues like neurotoxicity or even asymptomatic or chemical pancreatitis. So those drugs don't appear to be moving forward in the approval process. Then you have NS018, which is a drug that Serge Verstophic and others have been involved in evaluating early phase studies. So it's early. This is a very selective JAK2 inhibitor. And they've tested it in a refractory population that's seen at least one or more JAK inhibitors, and they have some very interesting results in terms of spleen reduction and symptom improvement. So I would encourage you to keep an eye on this one because I do think that this will likely continue to progress in development. Then you've got this active mid-phase, itacitinib. Itacitinib is a slightly different than the PAC. It's a selective JAK1 inhibitor, and we published a phase 2 study on this a year or two ago. I think this is a great drug. It can improve symptoms. It doesn't improve spleen as much as a JAK2 inhibitor does, but it's less myelosuppressive. So for me, this drug would be great in combination. So for those of you in the pharmaceutical business in the background, this drug in combination with other active agents would be a terrific partner. Momelotinib is an interesting story. This is unfortunately a failed phase 3 study. This was the 2 studies, Simplify 1 and 2. This is a JAK1/2 inhibitor. It's much like ruxolitinib, although it may target other pathways. And what seemed to differentiate this drug from the PAC was that it had an anemia response that we don't see with ruxolitinib. So with ruxolitinib, which is a great drug, you do get myelosuppression, it's expected. You're unlikely to improve anemia and unlikely to improve thrombocytopenia. But in this drug, there was actually an anemia response. But unfortunately, the way the trials were designed, this was considered a negative study. So I'm not sure what Gilead is going to do with these studies or with that drug, and if someone's going to pick it up. Now, the 2 last ones here, pacritinib and fedratinib, these are interesting stories themselves. I won't get into it today because it's too long of a story. But they were both stopped due to toxicity issues. In the case of pacritinib, it was put on a full clinical hold for about a year or so due to concerns of excessive mortality that was associated with bleeding and cardiovascular events. When you look at the data, and it's been done now by the FDA, that turns out not to be completely a concern. They relieved the hold, and now that drug is moving forward in the PAC 203 study, and to me, that drug is most notable and most effective in low platelets. It's less myelosuppressive than ruxolitinib, and I think can be given after ruxolitinib failure, as defined very strictly in the protocol, the PAC 203, and I think you'll be seeing more and more encouraging results from pacritinib as that drug moves on in development, hopefully continues to move on in development, because we need another JAK inhibitor. Now, fedratinib is also an interesting drug. It's a selective JAK2 inhibitor. It was also killed right at the last moment due to emerging issues of Wernicke's encephalopathy. So neurologic issues with this class come up, although I have to say with ruxolitinib doesn't seem to be an issue. This drug may be coming back to the FDA through Celgene, and we have to wait to see that. But that's a drug that could be delivered, again, second line to ruxolitinib. So the 2 areas for JAK inhibitors right now, to me, are upfront, low platelets, or upfront, very anemic and transfusion dependent, or second line after ruxolitinib failure. So Rux remains the only approved drug, and now really what the community and clinical trials are doing is combining it to other drugs to see if we can maximize or optimize the responses. So this is a slide I've shown a number of times from an ASH presentation. And it could be updated, but I haven't really, because the theme remains the same, which is that we have combined Rux, I say we in the generous sense, with multiple agents that either, for example, in the first category are combined with PI3 kinase inhibitors that are listed here. There's preclinical rationale for this. They target pathways that are already active and that could be active in the setting of JAK inhibition to improve upon the responses. And there's some interesting results that have come out already for the TG Therapeutics drug, and then the Insight study is ongoing. So it's still a little early to say whether this is going to really be an improvement over ruxolitinib, but you must keep an eye on that. Then you've got drugs that sort of make sense, don't necessarily have preclinical rationale. So adding an IMiD or adding danazol, synthetic androgen, to improve anemia, 20 to 40% response rates outside of ruxolitinib therapy. Why not combine them and try to offset therapy-related anemia and improve that aspect? The problem is that we haven't actually been able to show that actually occurs. Then you have the obvious epigenetic therapies, whether they're HMAs or histone deacetylase inhibitors. And although there's a lot of work that's been done on these by me personally and others, it remains a little bit unclear at this point how effective combining JAK-STAT inhibition with the panobinostat, at least. You get incremental benefits in spleen and symptom response and reduction in allele burden, but whether actually patients do all that much better is still murky. Then you have an assortment of other things, including immunomodulatory drugs and interferon, and then trying to combine it and integrate it, I should say, with transplant. So not in lieu of transplant, but how can we add ruxolitinib prior to transplant, even post-transplant, now with the GVH emphasis. That is still an ongoing, but probably routinely used approach in the community. So I'm not talking about JAK inhibitors. We're going to go on. We're going to talk about pentraxin-2 analogs and telomerase inhibitors. So what is pentraxin-2? It's serum amyloid P. It's an acute phase response protein. It's made in the liver, and it goes up as an acute phase response protein. But for reasons that remain somewhat unclear, it's low. It's been measured to be low in myelofibrosis. And it affects monocytic differentiation towards fibrocytes. So the agent can be used, a recombinant form, for example, PTX2, PRM151, can be used to dissuade monocytes to becoming fibrocytes, which then lay down fibrosis, which is an integral part of the disease. And some say it's an epiphenomena, others say that it's part of the malignant clone. But the PRM151 study was a phase 2 study that we did with other centers, including Serge, who led the study, and essentially was taking this IV drug, pentraxin-2, PRM151, giving it either weekly or every 4 weeks, either alone or in combination with ruxolitinib. And what I'm going to show you is the 13 patients that completed 72 weeks. This has been presented previously by Serge at ASH. The one thing I can say right away, it's a well-tolerated drug. We're not seeing a lot of toxicity with a synthetic or a laboratory-based form of a naturally occurring acute phase response protein. But we do see reduction in fibrosis. So here you can see at like 48 weeks, about 50% of the patients had at least 1 grade reduction in fibrosis. And if you use a sensitive technique, although not validated, computer image analysis, it's 85% of the patients have at least 1 grade reduction. But does that matter? So if you have a patient who has grade 3 bone marrow fibrosis, you give them an antifibrotic drug, which this is. Do patients who then have a reduction in their grade of fibrosis actually benefit clinically from that? And this would suggest that that may actually be the case. So again, this is not an erythropoietic agent. This is not necessarily affecting blood cell development. But what you do see is that the median hemoglobin went from 8.6 to 10.7 in these 5 patients, at least small numbers of patients, and the transfusion requirements went down. So it would suggest that reducing the grade of fibrosis correlates with a clinical benefit in anemia. That might also be true with thrombocytopenia from 37,000 to 52,000 and a reduction in platelet transfusion requirements. And interestingly, and somewhat unexpected by me, improvement in symptoms. So 70% of the patients, look at that line that's drawn below, 70% of the patients had at least a 50% reduction in symptom burden. And many of those patients were on the drug alone, not even seeing ruxolitinib. So why that would be exactly, I don't know, but we observed that. And we even saw spleen reductions, as shown here. So the drug does seem to have some clinical benefits that associate with reduction in bone marrow fibrosis, and the mature results of this will be out later this year. So the antifibrotic therapy, PRM151. What about imetelstat? Imetelstat's a telomerase inhibitor. We've talked about it even at this meeting, I think a couple of years ago, and I've heard Amy talk about it in MDS talks, and this is a drug that inhibits an enzyme that's important for adding telomeres, which are repeats at the ends of DNA. Every time cells divide, they lose these telomeres, and they get to a critical threshold where they can no longer divide. And this enzyme allows, and it's constitutively expressed in malignant cells, allows for the repeated addition of telomeres and therefore continued life. So imetelstat is an inhibitor, small molecule inhibitor of the RNA component of this enzyme. And Aiello Teferi presented this and now published it, I guess it was 2 years ago, in the New England Journal of Medicine. And this was an interesting study, an interesting presentation, because here in 33 patients, a pilot study at his single institution, he showed something that had not been shown outside of bone marrow transplant, which is complete responses. So these are morphologic responses. There were molecular responses, cytogenetic responses. At CRs, at least 4 patients and 3 PRs. And that's quite unusual. We don't typically see that. We definitely don't see that with JAK inhibitors. We haven't seen that with the pentraxin-2 analog. So that got a lot of attention, that giving this intravenous infusion may be able to actually target the disease in a very profound way and give you these deep responses. So that interest, and it was very quick, within 2 months in some of the patients, that led to a phase 2 multicenter randomized study led by Janssen called the EMBARK study, which is shown here. So this is randomizing patients with intermediate or high-risk myelofibrosis that have already seen a JAK inhibitor, ruxolitinib mostly, to either a higher dose, which is what Aiello used in his study, or a low dose of imetelstat every 3 weeks. So it's an infusional agent. And the co-primary endpoint is spleen and symptoms. So it's not complete response. It wasn't even initially overall survival. And unfortunately, this is publicly made available. The low dose was ineffective. That arm was closed. And the high dose didn't actually meet the pre-specified endpoints for the interim analysis, but was close. So we stopped accrual, and we're watching the patients for overall survival. Now, this drug is associated with myelosuppression in about 50% of patients, transaminitis, and a couple of the patients who had significant thrombocytopenia died of hemorrhages in the pilot study. So it's not an innocuous drug, but whether it's actually an effective drug, we're still waiting to get the mature results, which we hope to get to you guys perhaps later this year, maybe at ASH. Okay, so those are drugs that are new but not so new. SMAC mimetics, this is an interesting compound. So this was presented by my friend Naveen Pemaraju at MD Anderson. This was a phase 2 clinical trial of a drug called LCL-161, an oral SMAC mimetic in patients with high-risk myelofibrosis. What's a SMAC mimetic? So what are SMACs? SMACs are secondary mitochondrial activators of caspase, and these are molecules that negatively regulate inhibitors of apoptosis, which basically inhibit apoptosis and inhibit caspase activity, among other actions. So essentially, the bottom line is SMAC mimetics promote caspase-dependent and other mechanism-dependent apoptosis. So they're a pro-apoptotic molecule. So in this study of 38 patients that was presented previously, you can see the demographics here. These were patients that were pretty ill. They had low platelets, which is a poor prognostic marker in myelofibrosis. They had big spleens. The majority of them had seen previous JAK inhibitors, and most studies today enroll patients that have failed JAK inhibitors. And you can see the majority of the patients had high-risk disease. And there were responses out of these 38 patients. So there were 7 symptom responses. So there were 10 responses in total. So some of these responses were seen in a single patient had 2 different types of IWG responses. So there were responses in this subset of patients. But there were also toxicity. So fatigue, and this is seen in other trials and other diseases using a SMAC mimetic like LCL-161. Fatigue was an issue in 55% of the patients, as well as some GI toxicity that seemed to be relatively well managed, and a low degree of myelosuppression, I should point out. Interestingly, or sort of importantly, they were able to show they had on-target activity. So what they showed here nicely in the 10 responding patients shown on the top versus the non-responders on the bottom is that by Western that you really did knock down the protein CIP1, which is what the SMAC mimetic is negatively regulating. Okay, what about activin ligand traps? So I will spend less time on this because Amy already went through this in MDS. So sotatercept ACE11, which was the initial drug before ACE536, which is luspatercept, which is now moving forward in MDS and in myelofibrosis. This, again, was from our guys at MD Anderson that presented this study of sotatercept. This is an activin ligand trap, so it's an antibody that essentially captures the ligand, so it can't signal through the receptor. This is part of the TGF-beta superfamily. So this is a little bit different than TGF-beta 1 and 2 inhibitors, as it inhibits GDF11 and other activins. And it's been shown in models like black diamond anemia and other models to be effective in restoring erythropoiesis by removing negative repression of late-stage erythropoiesis. And that was not my question either. So this is the phase 2 study design of myelofibrosis patients that were treated in 2 cohorts of a 0.75, this is a subcutaneous injection every 3 weeks, or 1 milligram per kilogram. And their responses on study had to be for 84 days. So it's essentially looking for anemia responses. That's really the goal of a therapy like this. We're not really looking at fibrosis in the bone marrow. And this enrolled patients who were anemic or transfusion dependent. Again, hypertension was something that was seen, and this has been documented before with this drug, grade 3 in 3 patients, grade 2 in 2 patients, and then sort of myalgias and arthralgias were also described, but otherwise seemed to be well tolerated. This shows the 10 responders, the mean hemoglobin. So clearly is a drug that has an effect in a subset, so 10 out of the 33 or 38 patients that were enrolled, about a third of them, had an anemia response that was quite significant and clinically meaningful, as shown in this graph. So it seems to have efficacy. Luspatercept is the drug, as Amy had pointed out, that's moving forward now in a Celgene-sponsored study in anemic patients with myelofibrosis that have seen JAK inhibitors previously. What about BET inhibitors? So there's rationale for bromodomain inhibition. So bromodomains basically bind to acetyllysines on histones and are readers, epigenetic readers, as opposed to erasers or enhancers, and facilitate transcription of genes like NF-kappa B and c-MYC. So they're very important and integral to signaling pathways that are relevant in myelofibrosis, including the NF-kappa B pathway shown here in this cartoon, and c-MYC and cytokine signaling. So there's a rationale between inhibiting JAK-STAT signaling, which also affects acetylation of histones, in addition to shutting down the signaling pathway itself in STAT3, and then bromodomain inhibition to come together. And there's I should have cited it here, but there's a terrific paper that was recently published from Ross Levine's lab. Maria Kleppi was the first author, showing that dual inhibition of JAK2 and BRD4 in I think it was an MPL-driven murine model of myelofibrosis led to complete resolution of bone marrow fibrosis and inflammatory signaling, as well as extramedullary hematopoiesis by spleen reduction. So this seems to have rationale preclinically and in a murine model, this combination. Well, here's actually the slide showing it, resolution of fibrosis. Here they use JQ1, which is not used in the clinic. But what we are interested in using is CPI 0610, which is a Constellation oral bromodomain inhibitor. And there are 2 arms in this phase 1 study, actually phase 1/2 study now, monotherapy and in combination with ruxolitinib. And I just showed you the preclinical results. So nothing yet to talk about, but this is a drug and a drug combination I think you will see more and more of, and probably hear about later on this year at a meeting. Okay, lastly, maybe most importantly, most excitingly, at least to me. So this is an approach that I think is very exciting. It's a translational approach that comes out of our group and others, but in close association with Ron Hoffman at Mount Sinai, using this MDM2 inhibitor. When we started the trial, it didn't have a name. Now it's called Idesanutlin, RG7388, in patients with PV and ET. So for those of you who are not in the know, MDM2 is upregulated in PV, and you can see that, I think, you can see that here in the Western blot, and these are PV patients. MDM2 at baseline is elevated. MDM2 negatively regulates wild type, not mutated, wild type P53, and therefore can take and can shut the p53 pathway down, which is very important for multiple processes in cell survival. So inhibiting that interaction could lead to p53 activation and cell death and apoptosis. And what Ron Hoffman showed very nicely in the lab using primary patient specimens, both PV and MF, is that MDM2 is upregulated and is a target, and you can activate the p53 pathway, and he showed by increases in p21 and PUMA downstream from p53, and that in murine models, combining this nutlin, the class of agents are called nutlins, idasanutlin with interferon, which we know has activity in this setting, you can get synergistic reduction in the JAK2 allele burden in mice that are non-skin cell mice that are transplanted with CD34 cells that have been exposed to these drugs from primary PV patient samples. So the preclinical rationale is there, it sets the stage. We set out to do a phase 1 study simply to see can we get a safe dose and give this drug. We used it as 1/6 of the dose that's used in AML, and there's a large phase 3 study ongoing right now with idasanutlin in combination with cytarabine versus cytarabine alone. But we're using it at a very low dose, initially as monotherapy in the part A of this study. So it's 5 days, it's an oral drug. We were told there's going to be GI toxicity. We were told there was going to be cumulative myelosuppression, so we built in parameters to keep an eye on that in this study. But essentially, you can keep getting the drug every month for 5 days in a row, so it's not like hydroxyurea where you're taking it continuously, or necessarily Pegasus every week. And if by cycle 6 you have a response, you can continue getting the drug by IWG response criteria. If you do not, and you have no contraindication, you can get it in combination with Pegasus, which again, the preclinical studies would suggest is a very effective way of giving these two drugs. So what did we show? That MDM2 levels are in fact higher in these 12 patients that were enrolled into this phase 1 study. We ended up looking at 2 doses, 100 and 150 for 5 days. We didn't really go higher than that. We didn't think we needed to. And we showed that, that we can activate the pathway by showing that MYC1 levels, which are downstream from p53, go up by day 5, at least here in the 6 patients that we had the day 5 plasma samples from. What about toxicity? So there were only 3 patients in this cohort of 12 that had toxicity issues, grade 3 fatigue, headache, and myalgias. I can tell you personally that I wasn't convinced that any of these were necessarily drug-related, but they were considered at least possibly related to the drug. Otherwise, it seemed to be well tolerated. We were warned that there would be potential for grade 3 and 4 GI toxicity, so we prophylaxed the patients really well, and we didn't see that. So this wasn't a major reason for discontinuation. And I'll get to the punchline because I'm running late. But the punchline is that out of the 12 patients that enrolled, we had 7 of the patients had an overall response rate. So either CR or PR. They normalized their counts, their spleen went down, their symptom burden improved. And that's somewhat remarkable in a population that's second line. It's seen hydroxyurea, it's failed hydroxyurea, and now we're getting response rates about 58%. And in the patients that went on to Part B, so the 4 patients who didn't respond, at least for the 3 patients that were evaluable, 2 of them had responses. So we have an overall response rate of 75%, which is unusual. And the last couple of slides, I'll impress you, or try to impress you, with the fact that we got driver mutation burden reduction, so the variant allele frequency is shown at the bottom for each one of these, and then the number of cycles above the columns, and then it's color-coded by whether they had a clinical response, CR, PR, or NR, and what you can see is they had responses. What's interesting here is the 1 patient who didn't have the response, this patient turned out to be p53 mutated, so that was actually satisfying. I didn't know that until after we ran the study, that the 1 patient who didn't respond was the 1 patient who would not be predicted to respond because they have the p53 mutation, and this drug really is only effective in wild-type p53 setting. And here's an example of a patient who had a nice response with bone marrow, reduction in overall cellularity, and at megakaryocyte atypia, and I won't dwell on that. I'll just let you know that there's an ongoing phase 2 study. It's a global study of idasanutlin in patients who have failed hydroxyurea. This is just PV patients at a dose of 150 milligrams 5 days in a row, and I'm hoping that we will start accruing more rapidly to that study and have some data to share with you guys maybe next year. But that's an exciting drug. So summary of the drugs, new drugs for MPN. So next generation JAK inhibitors, whether it's fedratinib or pacritinib, likely will be available as second line, and I hope that they will be. JAK-based combination regimens, so far there's no winner. It's kind of like MDS and combining things to azacitidine. In patients, you can sometimes see some additional responses, but there's no clear winner here. The pentraxin-2 analog, PR151, and imetelstat, the telomerase inhibitor, have yet to really present final data, and it's unclear how they'll move forward. I think the early data on the SMAC mimetic that I showed you and the activin ligand traps, so tadalafil, show potential anemia responses, and that's an unmet need in myelofibrosis. And then the bromodomain inhibitors like the CPI drug or other drugs are still early on, but may not look that great in other myeloid malignancies, but I have a feeling will be good with JAK inhibitors in myelofibrosis. And then lastly, I tried to impress you with the MDM2 antagonism. It has rationale, it's tolerable, and we see an early signal, and now we're looking at a phase 2 study, and we'll have that next year. So with that, thanks everybody, and that's my talk.